All right, I'm just gonna move our interpreter over to the webinar. Looks like it's taking a little longer.
Okay.
All right, great. We have here. So Mr. If we can
Yes,
just have the screen share, it looks like the PowerPoint went away.
Mhm.
Oh, it did, all right. Let's see. How's that? Back
Yep.
again?
It is right there. Perfect.
Looks like people are joining in. You want to wait a little bit more for a few more people to join, or whenever you tell us, Maria, we'll start.
Yeah, feel free to start now.
Okay, well, welcome to those of you who are here. And I think what I understand, there'll be more people joining us. I see the numbers actually are going up as we're speaking. So other people are joining. Just before we actually launch in the presentation, a little bit of information about the interpretation. So let me go to the next slide and let Melinda, our interpreter, explain how that works.
Buenas tardes, bienvenidos. Ahorita voy a leer la información para si quieren escuchar esta sesión en español. Como pueden ver, el control para escuchar esta sesión se encuentra en seminarios de web. Haga clic en la interpretación. Después, el paso número 2, haga clic en el idioma que desee escuchar. Y si desea escuchar la versión solo en al orador, haga clic y ponga audio original.
I think there's one more. I don't know if anything else
Yes,
you need to say
there's
on
one
this
more.
one. Yeah,
there's
right.
one more. Yes.
Okay.
El siguiente paso es el control. Si está haciéndolo por medio de su celular, en la parte de arriba, como pueden ver, habría el control de la página. Haga clic donde están los 3 puntitos. Después haga clic donde dice interpretación. Haga clic en el idioma que desee escuchar, en este caso español. Y nuevamente, si desea escuchar la versión en inglés, escoge el audio original. El paso número 5, apriete el botón que dice Done. Está hecho. Thank you very much.
Great. Thank you for that, and thank you for doing the interpretation. So yes, we'll go ahead and get started then. So hope everyone can see and hear the slide and hear me. I'll introduce myself, although I think you've probably already heard who I am in joining this session. But anyway, my name is Paul Glassman. I'm a professor and associate dean for research and community engagement at California North State University College of Dental Medicine, which is in Elk Grove, California, just a little bit south of Sacramento. And I was honored to be asked to present at this summit. In talking it over with the conference organizers, we thought that a couple different things might be useful to talk about during this session on dental care. So this is an agenda, the kind of things that we're going to try to to cover. First part, we'll spend a little bit of time about adopting mouth healthy habits. And this is really going to be from the point of view if you are a parent or a caregiver, or an individual who's got some challenges with having good dental health, some things to think about. And then once we spend some time on that, we'll talk a little bit about dental visits. If you're someone who's trying to arrange a dental visit, some things and some ideas about how you can have those dental visits be more successful. And then you'll see as we get into this that my belief is that the dental care system that we currently have, where most people think about dental care as something that happens inside of a dental office, is too limiting for most people. And in fact, we have the ability to have people have good dental health and even get dental care in a lot of different ways outside of dental offices. So we'll talk a little bit more about evolving systems of care for people with disabilities. And then finally, we'll come back to this idea of the challenges. You heard about it from former Assembly Member Frazier this morning. You heard about it from, if you're watching the video of Assembly Member Rambula just before lunch, you heard about it from him, but it's this idea of shortening the line for sedation and general anesthesia, and then specifically the bill that Assembly Member Rambula has introduced, AB 2510. So that's the plan. If you have some things that you want to ask about, we'll certainly allow plenty of time at the end, but I've also got this little screen up here where I can see the chat. And if you have some particular questions that you want to address before the end, please type them into the chat, and I'd be happy to address questions as they come up. So we don't have to wait entirely till the end to answer questions. And I see that some of you have started to put your name and who you are or something about the organizations you work with in the chat. If you're so inclined to do that, that'd be nice, because I can't see or hear any of you. I actually don't know who you all are. So it'll help me a little bit to get some sense of whom I'm talking to. So if you can say something about yourself in the chat, that would be lovely. All right, well, let's launch into it. So first thing I said about mouth healthy habits. So what do we even mean by what is this idea of mouth healthy habits? Well, it's basically the idea of cleaning someone's mouth or your own mouth and eating habits, those two things, sort of cleaning and eating. That's what we talk about with mouth healthy habits. And some of you may realize this, but it turns out that these couple things, how well you clean your mouth and what kind of food and you eat and when, are actually the key to oral health. Dental disease is one of the most preventable diseases of all the different things that people struggle with. And by adopting good mouth healthy habits, so the way mouths are cleaned and what we eat, we can actually mostly control dental disease. Sometimes there are things that need more advanced care, but most people can control most of their disease by just adopting good, again, this term, mouth healthy habits. So I don't want to give the idea that it's easy. In fact, habits are really hard to change for anybody, and can be even more challenging if you're working with someone with special conditions where they may have some trouble understanding what you're recommending, some trouble cooperating for various reasons, some trouble carrying out certain procedures. So I don't want to give the idea that it's easy to do, but it certainly is the basis for dental health. Is what happens with people on a daily, what you do every day has much more to do with whether you're going to have good dental health than anything else that's going to happen, or anything can be done by a dental hygienist or a dentist. So there's a set of training materials that have been designed specifically for caregivers of people with disabilities. It's called Access for All Smiles. And this was something I contributed to. I was one of the consultants on this. It was actually produced by a group called Macmillan Health and funded by the Delta Dental Foundation. But it's actually got quite good materials in it. I don't have time to go through the whole thing, but I'll give you a little flavor of some of the things that are in there, and encourage you, if you're involved in either yourself or helping someone attain better oral health, to really dive into these materials and study them and take a look at them and benefit from all the good ideas in there. You'll see when you look at them that there's sometimes you see the word, it's framed for adults, that the focus of this website and all the materials in there is for adults with special needs. But, and I know the focus of this conference is for children and youth, but when I look at the materials, the things that they say on there are certainly applicable all across the health spectrum. So I don't think you need to worry about if you're dealing with a child or a youth person that you need to worry about not having the materials don't apply, because they really do apply. So, at the beginning of these materials, there's a description of what they're all about. And, it talks about the fact that everyone deserves a healthy smile. And then some of the things that are tried to be addressed. The goals of this whole series of training materials are the importance of dental health, making sure people understand why it's important, some of the consequences of not having good dental health, what are the best practices for daily mouth care. Again, this idea of adopting mouth healthy habits. I use the term mouth healthy habits. They use the word daily mouth care, same thing really. Often that there are some challenges that can be addressed by what are referred to in these materials as behavior support techniques, which we'll get into in a little bit. And then, some things about how to encourage the desires and goals of the people that you might support. And so the contents here, there's some short videos, there's some tips about motivational interviewing, written modules, and then interactive handouts. So if you were on this website, you'd see a whole list of written things. These are all PDF files that are just downloadable files that I'll show you some of the examples of some of the contents in a few minutes. So you can see there's a whole bunch of different topics that are listed here, which are just very useful if you're trying to work with someone with some challenges having good daily mouth care. And then there's a series of videos, which also same topics, but the videos are a little bit more of a real-time illustration of what are the things that are being talked about. And then finally in the materials, there's a couple of structured pathways. You can go through what's called a 1-hour caregiver training or a 2-hour caregiver training, and it sort of guides you obviously the 1-hour one doesn't include everything, neither does the 2-hour one, but they guide you through various pathways through the material. So I want to just dive in a little bit on only really one of the aspects of what's in the materials, which is about behavior supports. This seems to be kind of a pretty common issue that certainly I get asked about when I'm working with people with various kinds of disabilities or their caregivers, is some version of, yeah, it seems like a good idea, but we have trouble, getting it done. They don't seem to understand what they need to do. They're resistive to having me put a toothbrush in their mouth, various kinds of things that mean that there are some behavioral challenges. So this is one of the handouts about behavior supports. It talks about behavior support plan, and it talks about as a caregiver, some of the things you can do, including the things that are on this part of the list here about identifying the reasons, having someone overcome their fear, build cooperation, and build self-help skills. So some of the techniques that are included in the materials for doing those things are these, which is, and I'll go through some of these a little bit in a couple of minutes, something they call adapting the environment, and we'll talk about that, but that's actually creating a sort of time and place and circumstances where you're more likely to be successful. There's a thing called the ABC model, which we'll just touch on a little bit. There's some things about incentives and shaping and desensitization. So these are all different techniques, and I'll not have time to go through them in great detail, but I'll explain a bit about these various techniques to you as we move forward. So the first one, which is the environment, some of the tips that they recommend are the ones on the screen here, which is, creating consistent, predictable, agreeable routines around daily mouth care sessions. So if you're working with someone who's got some challenges in having this done, one of the basic principles is don't make it a fight. Try to make it as pleasant as possible. And even if that means initially you're only getting a little bit done, you're not getting a thorough job of cleaning their mouth. If you can make it a pleasant experience, whatever it is you're going to get done, you're more likely to, next time you come back, to have the person want to do it again or being willing to do it again, and sort of gradually build on that. So if you can create some kind of environment where it's not a fight to do it. So having some kind of consistent routine, most people like routines, certain time, place. Obviously that depends on you, your family, your circumstances, but find a consistent time and place to do daily mouth care procedures. It doesn't have to be the first thing when you get up or when you go to sleep, just sometime which works when the person doesn't have a lot of other distractions, when there's not a lot of other things going on, when you're not pulling them away for something else that they really want to do. That would be great ways to set up a timing for this, and then try and be consistent about it if you can. So it just becomes part of, this is what we do every day. We get up, we get dressed, we have our meals, we clean our mouth, whatever the routine is. So that's just a part of the daily routine. Certainly being responsive to the needs and interests of the person. So if there's some way you can, if they're communicative enough with you to talk about what's their preference for the time of day, that would be a great thing to do, is to figure out from them how to structure it for them in a way that works for them. If you can give choices, they can be as simple as, you want to reuse the red toothbrush or the blue one. It could be as simple as that, or there could be choices about, do you want to watch your favorite TV show before we do this or afterwards? But again, to try to make it so that it feels as least disruptive for the person's life as possible. And then, of course, if you're trying to help someone build these skills, having you stay engaged and be involved and sort of encouraging them as they move through a cleaning session is super helpful. And we'll come back to that one in a minute. And then last one says identify and reduce distractions or behavior triggers. So, if you're doing it in a place where you're trying to get them to brush their teeth and there's some people in the other room having a good time with something, or the TV's on and it's just less likely to work. So if you can find a quiet time, a quiet place away from other distractions, that's really helpful. All right, so those are some tips about just setting up the environment where you're going to actually do the daily mouth care activities. Another one is this idea of behavior supports. And then again, this just says it doesn't have to happen in the bathroom, actually. So a lot of people think, well, you got to be in the bathroom because you got all this toothpaste in the mouth and then you're going to have to spit it out. And what do you do about all that? But for some people, it actually works better you can imagine I don't have a photograph of this, but you imagine a caregiver sitting on a couch and the person's laying on their couch and they got their head in your lap, and you can actually be able to see their mouth better that way. If you're going to do that, it's hard to spit out. So you might just use a sort of wet toothbrush just to soften it up and clean all the debris off of their mouth, and really be able to see well and get to all the parts of the mouth. And maybe afterwards you go into the bathroom and then puts the toothpaste, which has the fluoride, which is really beneficial. So you can think of being creative and do it in a way that's going to work for that individual. Okay, this next thing is about something called desensitization. And for me, this is really the crux of the whole thing. If you have someone where at the moment they're not able to do a good job of daily mouth care, basically the idea is break it down into small incremental tasks. Instead of thinking, okay, we just got to get your teeth brushed today, I don't care what it takes. And if it takes a big fight, we're going to get it done. If you can break it down into small tasks and then introduce the tasks one at a time, once they're pretty good about the tasks that they're doing, make that a pleasant thing, even if they don't get it all done. I mean, you don't want people to go for years and years without cleaning their mouth well. But if you can break it down to small tasks and later on get it more thoroughly done, but start out with a pleasant small thing, and I'll give you some examples of that in a minute. And then, so really it's just a gradual introduction to things that you think would be helpful for them to do. So you can see at the bottom it says it includes gently introducing each step, having time to build skills at their own pace, feeling more capable as they learn each step, and then building trust between you and the person support. So what's really key to that, as I've said it a couple of times, so I'm sorry for repeating it, but make sure at each session that it ends well, that it's a pleasant session. So don't push them beyond the point where they're feeling okay doing it and you end up with a fight, and what they remember afterwards is the fight rather than whatever kind of success they had in mouth cleaning, for example. So you want them to remember that it was a relatively okay or even pleasant experience, and that means not pushing them beyond what they're capable of doing on that particular day. That's the basis of desensitization. Let's see, I think that's also was on the previous slide. So just as an example of some steps, let's say you're trying to get someone to brush their teeth and they don't really do much of a job at it. You might think about, okay, how can we start with something that's really kind of far away from a full toothbrushing job, but something that they can actually do and feel good about and be successful. So, the first step here, maybe that they'll allow you or them to take a look in their mouth. Maybe that's you looking or them just looking in a mirror, but just start out with that. That's really pretty innocuous for most people. So if you can get that done and they feel good about it, they kind of get used to the fact that there's some focus on their mouth, that's great. And when they're pretty good at that, maybe they can, allow you to look in their mouth with some kind of a little mirror or something, or maybe at some point you start to advance the front teeth of the toothbrush. It could be just touch. That's it. So that's all you're going to do today. Just touch the tooth with a toothbrush. Again, the real goal is to make sure that everything you're doing is pleasant or at least okay for the person, so that they can remember that, yeah, this toothbrushing thing is fine. It's not a big problem. And whether they remember that intellectually or just experientially, still just building that confidence that this is not something to be worried about can be helpful. So this series of steps I have here may be different for someone you're working with, but just an example of maybe in a particular person, you decide you're going to allow them to touch the front teeth with a toothbrush at the beginning, and then pretty soon you're going to get them to hold the toothbrush. And then either you or they're going to allow you to do it, or they're going to do it is to brush just the front teeth for 5 seconds. And then, after a couple of days of that seems to be doing okay. Maybe you're going to do that for 20 seconds. And then, you're going to brush the outside of the side teeth, and then eventually you're going to start to brush the inside teeth, and then pretty soon you've got them comfortable brushing all of the teeth. So hopefully it's fairly obvious what we're talking about here is sort of a gradual introduction, letting them feel comfortable and have a good session no matter what it is for each particular step, and then moving on to the next one. And even some of the steps like holding a toothbrush can be broken down if it turns out that that's moving too fast for them to really hold the toothbrush, and maybe just touching it first and then gripping it and without picking it up and then later picking it up. So you'd have to be creative about what are the right steps for the person to be able to actually have a good session each time and be able to build on it gradually. Okay, so that's some of the things about desensitization. I want to add in now something that just takes it to another level, which is what referred to here as incentives. So incentives means not only just trying to do something and hope that they get it done, or try to make it a pleasant experience, but offer some kind of additional bonus for getting that thing done. So whatever it is, you're working now on today's, we're working on brushing the front teeth for 5 seconds. So be able to let the person know that there's some kind of an incentive for them to do it. It might be, say sugar-free mints or gums or a stick of gum, or it might be something like going for a walk, or after we do the toothbrushing session, we're going to watch our favorite TV show, or we're going to listen to our favorite song, or some special object they're going to get, or some kind of favorite game or activity, or spending one-on-one time with you, whatever it is, to help them understand that if they get the session, this thing done that you're working on today, then they get this incentive comes afterwards. So that's motivating for them to want to do it. And obviously you have to pick something that is motivating, something that they would want. And also you have to be a little careful with incentives, because something that's an incentive today might lose its incentive value if you do it too often. So you might have to think about changing the incentives. Maybe you started out with some kind of favorite song, but that kind of got used to that, and that's no longer incentivizing. So you pick something else as time goes by. But the basic idea is, in addition to just the slow approach, adding in incentives is sort of upping the ante to give them another encouragement and reason to want to get that particular step done on that day. And then sort of putting those two things together is a technique that's called shaping. Maybe some of you are familiar with this already, but for those who are not, it's sort of a combination of desensitization and incentives. So you break the task down into a small set of steps, and then for each step, you offer some kind of incentive, and then you might repeat that as many times as they need to feel like, yeah, they can do that step pretty reliably, and it's not a big deal for them, and they're feeling okay about it. And then you up the ante a little bit. Now, instead of brushing for 5 seconds, the next time, in order to get the incentive, they got to brush for 20 seconds. So now, today you've been doing great. Today we're going to do a little bit longer, and then you'll get your whatever the thing is. We'll go the walk, or we'll play the game, or whatever it is. So it's the idea of, at first they get the incentive for a very, very small thing, and then next time they have to do a little bit more to get the incentive, and so on and so on. So it's using the incentives to gradually build skills as time goes by. So this is sort of a series of steps about shaping, and it says, decide what the goals and steps are appropriate for the person you want to support. So that series of steps I showed you are just an example. They may not be the same for everybody. Figure out what are the rewards or incentives that you can use after they make the small step. Begin to increase expectations gradually so that they can complete multiple steps next time before getting a reward. And you pace that. Remember, the goal is every time you're with them, each session should end up being pleasant, and they should feel good about it. So that's how you determine the pacing. And then, eventually you're only going to give the reward when they do the whole thing. And then once they're used to doing it, you may not have to do the reward forever. You can start to sort of fade that out and not do it as much, and it just becomes part of it. Then it becomes a habit, and they just do it as a part of their daily routine. Okay, so that's a series of steps on behavior supports. Again, there's many other materials in those training materials. I don't have time to go through any. I'm not going to go through any of the other ones today, but there's some really good handouts and videos. And so I encourage you to take a look at them if you're working with someone to help them adopt mouth healthy habits. I'm going to show you now a couple of things that we've been using to train families and home visitors who are working with pretty young children. And there's a couple of things here that are just some things to realize about dental care and dental health. So this first one is just something that, and by the way, I gave the conference organizers this whole slide deck, and they have a handout, so you should be able to get all this stuff. But this is just about, cleaning teeth, and the idea is that when the child is first born, if you're dealing with very, very young children, you should still actually wipe their mouth out a little bit, just a washcloth actually before they have teeth. And then once they have their first tooth, you want to take a little, just a teeny, teeny dot of toothpaste on the washcloth and just rub it on that tooth. So as soon as they have a tooth, yeah, begin to use a little toothpaste on it. And then as the child gets a little bit older and their teeth start to come in more, you switch from the washcloth to the soft toothbrush, and then eventually you're hoping that becomes a habit and the child starts to do it themselves. It's so much easier if for many people, it's too late. If you already got a child who's 4 or 5 years old or 8 years old and is really resistant, it becomes more difficult. If you can catch it really early and it just is a part of just what happens every day, it gets much easier because it just becomes a habit. All right, so that's kind of teeth cleaning for very early in life. This other one is about caring for babies' teeth. Why? And just a reminder that teeth are actually critical for speech development, making sure that you get their teeth cleaned really early on, prevent toothaches. So there's some myths in some groups. People think, oh, they're just baby teeth, they're going to fall out anyway, so why bother? But actually, baby teeth can cause lots of problems. They can cause toothaches, they can cause infections, they can even cause damage to the adult teeth that are going to come in later. So they're necessary for chewing and proper nutrition. So it really is important to try to start as early as they have any teeth at all. Sometimes people ask, well, okay, so for a young child, how much toothpaste do you use? And so this is some guidance about that. From the first tooth to the first year, the first little tooth just starts to come in. That's the idea of the washcloth with just a dot of toothpaste on the washcloth. From about 1 to 3 years old, and they're ready to switch to a toothbrush. This is a grain of rice, and they're using food particles in this example here because most people know how big a grain of rice is or how big a pea is or an almond. So 1 to 3 years, a little grain of rice, little dot on, really is not much on the toothbrush at all, a child's toothbrush. And then as they get a little older, about 4 years old, you increase it about a pea size bit of toothpaste. And then finally, when they get 6 years older, it's an almond size bit of toothpaste. So again, the food analogies are not that you actually put a pea or an almond on the toothbrush, but that's just the size of the bit of toothpaste you're using. Okay, so then that's the amount of toothpaste. And then I think the other thing that's important to realize is fluoride, how beneficial fluoride is. It helps prevent tooth decay, and there's various sources. It's in tap water in some communities, but not all. It's in toothpaste. And then, if you're living in a community where they don't have fluoride in the water, a lot of people actually don't drink tap water because there's, particularly if you come from another country where the tap water had bacteria and it wasn't really safe to drink, buy bottled water, and the bottled water doesn't have fluoride, even if your water supply has it. The other thing I wanted to say about this, though, is that there are lots of, I'd say, misinformation, bad information, untrue information around about fluoride. A lot of people saying it's poison and your kids are going to get all kinds of diseases. I don't know that I'm going to change anyone's mind if you have that feeling, but there is just reams of scientific information that says, and in fact, it's not true, that in the amount of fluoride you're getting from toothpaste or from water, it's very safe. There's no associated other kinds of medical problems. And it's just really critical to have your children or people you're working with have good dental health. So I'm strongly in favor of using fluoride. It's so much better to use that and then to deal with all other than otherwise you're dealing with all the consequences of toothaches and infections and all kinds of other things that are much more troubling. So encouragement for fluoride. Some other best practices have to do with sugar. So a lot of people don't realize how much sugar is in stuff that we eat all the time. Obviously just plain water doesn't have any sugar in it, but even milk has about 3 teaspoons in an 8-ounce serving. And you can see fruit juice has a lot more. And then fruit snacks have a lot of sugar. And then applesauce, even more sugar. And then anything like cola, like Pepsi or Coke, is really, it's the double whammy because, the way teeth get decayed is that the sugar feeds the bacteria that are in our mouth. The bacteria produce acid. The acid dissolves the teeth. And the things like Coke and Pepsi and any kind of sugary drinks, they're not only have a lot of sugar in them, but they also are very acidic. So they're not only helping the bacteria produce acid, they're supplying the acid all by themselves. And those are the worst things in terms of having healthy teeth, is to be able to use a lot of that stuff. And I'll get to it in a minute. It's not just using it at all, but it really is important about when you use it. So this next chart is just showing it's not only how much, but it's also how often. So what happens is that little squiggly line there is a marker of how acidic someone's mouth is. So most of the time, most of us, their mouth is in kind of in a safe zone. But as soon as you put some food in your mouth, like a bottle, you know, there's sugar in the, if you're feeding your child with milk, there's sugar in the milk, and the bacteria start to produce acid. So you can see how it drops down into the danger zone. The acidity of the mouth drops down in the danger zone. It doesn't last that long, so it kind of goes back up by itself. And then breakfast, it goes back down again, then a snack, and then sippy cup with apple juice, multiple times during the day. So you can see that if you're having this kind of diet where they're having sugar for the bottle, sugar for breakfast, sugar for snack, sugar for apple juice, sugar for snack, they're getting exposed to sugar and its acids multiple times during the day. So it's actually much better. It's not that really anybody's expecting that you're going to raise a child without having to have anything sugary, but it's much better to reduce the frequency. Don't have it as often. So what the guidelines typically are is, yeah, if you're going to have sugar, have it at the meals. So fine. Even something as bad as Coke, have it at the meal. If you can get your child to at least rinse their mouth out after each meal, or even better, brush their teeth, which is not only easy to do, that's much better. And then just have water or non-sugary things in between. You're much less likely to have a child grow up with tooth decay than if they're having the sugar and the acid all day long. So just to bring the next couple of things, just are basically the same thing, which is, best practice for young children, limit drinks with sugar to meal times. Yes. And then same thing with food, sugary foods only at mealtime. So I sort of make the joke, if you love chocolate cake, eat the whole cake during at lunchtime. But of course, that has bad consequences for diabetes and other things. So don't eat the whole cake. But the point is, don't do a little bit all day long. Just concentrate it. If you're going to have sugar, and for your child you're working with, try to limit it to meal times, and then rinse the mouth out afterwards. Or if they do have something sugary in the middle of the day, if there's some way to at least rinse their mouth out, fabulous if they could have a sugary snack and then rinse their mouth out, or even brush their teeth with a little fluoride toothpaste. That's even best, but at least rinse the mouth out after some sugary snack at the meals or between meals. Okay, so that's a bit about sugar. The next thing I'm going to talk about is about sort of recognizing the early signs of dental disease. So, normal healthy teeth typically look like that. They're pretty. That's not always bright white color. They're often a little bit yellowy, which is normal. But this is the one I want to show you. See here, I don't know if everyone can see these little called white chalky spots on the teeth. That's actually the beginning of tooth decay. It's the beginning of tooth decay, and I'll come back to that in a minute, but that actually can be fixed at this point without going to see a dentist. When you get to the point where they're actually starting to develop holes in the teeth, like these here, that's a little bit too late to be able to fix it, which is better daily mouth care. Then you're going to have to need some professional intervention when there's actually a hole in the tooth. And certainly when it gets to this point where you've got, teeth are just badly decayed, and then you got infections, and there's toothaches, and there's all kinds of terrible consequences. So if you can catch it at this early stage, let me just show you a more close-up picture of that. We're talking about, again, these sort of white spots on the teeth. This can all be repaired. I'll show you in a minute about how to repair that at home. This one spot here, actually, it's now broken through, and there's a little bit of the underlying tooth exposed. So that one is past the stage of repairing, but at this stage, it can be repaired. So question is, how do you repair that early dissolving of the tooth? Well, naturally, calcium and phosphate in the saliva can heal that part of the tooth. If your child has a condition where either naturally by themselves or they have some medication that are causing their mouth to be dry and they don't have much saliva, their risk of having decay goes way up. And so the other thing that's critical to understand is that fluoride is really very important. The fluoride actually makes the tooth more resistant to acid. So even when there is some acid that's produced by the bacteria, they're less likely to dissolve the tooth. So that, you know, I don't think I'm going through all the details. A little, that's sort of some background about sort of things that you can do at home on a daily basis. The most important thing is what happens on a daily basis to create better health. And earlier you get going with these things, the better. So I want to stop at this point and see if anybody has any questions about these mouth healthy habits before we move on to some other parts of the presentation. You can type things in the chat if you want to. There's not that many of you here, so unless unmute yourself and talk, you can. I'm not sure if your screen will allow you to do that, but at least type it in the chat if you got any questions about sort of the daily mouth care activities. Wait another couple seconds for that, and if I don't see anything appearing in the chat, we'll move on to the next section. What do you feel about the Pseudoprox or Samba toothbrush? Well, there's a lot of different kinds of toothbrushes that are out there now. I'm not actually familiar about those two particular ones. Some toothbrushes out there have, there's manual toothbrushes, which are just a typical bristle. There's electric toothbrushes. Some toothbrushes have double sides on them, so you can brush the inside and outside at the same time. There's really no magic about what toothbrush to use. Really, the key is to be rubbing somewhere on the surface of the tooth to get the bacteria. When the bacteria first start to form and sort of cake up on the tooth, it's pretty soft and it can be brushed off pretty easily. If they sit there for a long time, they actually harden and it becomes harder to get them off. So I'd say whatever toothbrush works. Electric toothbrushes have this vibrating action. Some of them do, like the Sonicare and others, that actually help to loosen up the plaque. Some people are kind of sensitive to that and they don't really like the vibrating feeling in their mouth. So it depends on the person you're working with. So I say there's no magic to the toothbrush. It's just a matter of using whatever will work best for the person you're working with, and it can actually clean the stuff that builds up on the teeth off. Okay, don't see any other questions. What age should flossing be encouraged? Right. So I didn't really talk much about flossing, but let me add it in now. Thank you for that question. So when children's teeth start to come in, typically they come in and there's a space between them. You know, this tooth comes up, this tooth comes over here. As their mouth grows and they get more teeth, they come together and then they're touching each other on the sides. So at the point where you can't brush with a toothbrush the two teeth because they're touching each other, that's when floss can be helpful at cleaning between the teeth. So that can be pretty early. It can be, 3-4 years old that the child is already at the stage where flossing would help. Flossing is a little bit more difficult for both the caregivers and for people to accept. I find that and some of you'll see in some of the materials I didn't go over this morning that I referred you to, there's actually techniques about how to floss. There are little floss holders that it's like a plastic thing with a fork on it, and the floss gets wrapped around that. And that's easier to use than the floss where you have to wrap it around your own fingers. So I would say that as soon as the teeth are touching would be the ideal time. Sometimes for a 2-3-year-old where, it's a little difficult, and I wouldn't put a huge emphasis on it. By about 4 or 5, yeah, if you could start to do that, it'd be great. I'd say it's secondary to brushing. Absolutely. Brushing and cleaning the teeth is the most important thing. Using fluoride toothpaste is really important. And then adding in floss is actually a really good thing, because you can't really brush that well between the teeth once the teeth are touching each other. Let's see, G-tube, aspiration issues, sensory issues. Do you not use for aspiration issues, but it's in the water here. Yeah, so someone's on a G-tube. The myth is that they're getting fed through the G-tube, and then therefore they're not having sugar in their mouth, and therefore it's not such a problem. It's actually not true. That just naturally, even in the saliva, they are still susceptible to dental disease. So it's still important, even with someone who's on a G-tube, to clean the mouth, do some of the same things we were talking about. The thing about fluoride and aspiration issues, I agree. You want to be careful. You don't want to have a bunch of stuff that takes swallowing, and you don't want to have the person choking. So I'd say don't not use it. That's a double negative. Continue to toothbrush and continue to use fluoride, but do it little bits at a time, so they don't have to worry about swallowing it. So as I said earlier, a nice way to start would be just a damp toothbrush, or you're just using that to clean any debris that's built up on the tooth. Start with that. And then just a little teeny bit of fluoride on the toothbrush to go back again and just get it to sort of coat the teeth. So there's not a big glop of toothpaste that has to be swallowed. So you want to be careful about that, because, rightly, I'll say hello, Donnell. Nice to see you. I don't see you, but hear you on. I see that you're on the webinar. Yeah, it's but it's still important to do. Just be careful about not too much, so you don't have to worry about the swallowing and aspiration issues. Let's see. There's another question I think I missed up here. What is the best course of action we see orthodontic training, particularly brace for children eligible for Medi-Cal? Many clients hold these services not covered by Medi-Cal. Well, that's a little bit tough because if you don't have some coverage for orthodontics, it can be expensive. There is the for children with pretty severe disability conditions, there's a special orthodontic program through CPS, I think is the name of it. I'll have to look that up and tell you for sure. But other than that, it's actually, I don't really have any good recommendations for that, because without some kind of coverage, orthodontics can be expensive. And so, you know, there is both the Medi-Cal, and I don't know if people are aware of the services for every county has some kind of indigent care program that covers dental care for people who are slightly above the Medi-Cal eligibility. So that's something else to look into, is what kind of other messages might be, other kind of services might be available. But it is a real issue, and I don't have a great, CCS access orthodontia, but there's certain eligibility requirements that have to be a fairly severe condition for CCS, and they have to be able to demonstrate that this orthodontic treatment is going to be instrumental in working with that condition. But it still is something to look into. So if you're working with a child, or you have one who's doesn't eligible for Medi-Cal, CCS is another thing to check out. Good. Thank you for all those questions. Okay, well, there'll be more time to ask questions later on. So, you know, keep on thinking about them, and we'll come back to more questions later. But I'll move on now to talking a little bit about dental visits. So if you're going to take your child to see a dentist, then I think there's some things to think about. And my recommendation is, and this is going to sound like I'm saying something that may not be so easy to do, and it's true, it's not so easy to do, but if you can find a dentist who's willing to talk to you before you bring your child in for the visit and help to plan for the visit to make it more successful, that is a great thing to do. Actually, you can present it as a benefit to the dentist to say that I'm bringing my child in. I have some information I could give you that I think will make the visit go better. Is it possible we could have a time to get together and talk about that? Most dentists would be very excited about getting some tips about how to make the visit go better. They don't like it when a visit doesn't go well either. So if you can offer that as a bonus to the dentist, then I think that would be helpful. So here's some things, if you're going to meet with the dentist ahead of time, some things that you might want to give them some information about. So first of all is, make sure that they understand the person's condition that you're bringing in. I think it's important also that the dental office is treating everyone there. There's a tendency for people, particularly if someone is not verbal, to kind of ignore them and talk to the caregiver. So you can encourage them. When I bring my son or daughter in, or whoever you're bringing, do me a favor and talk directly to them. I'll be here and I'll help to interpret or say things if I need to, but actually talk to them, because it helps them feel more comfortable and valued. If you can set up the appointment so there's short wait times in a quiet environment, let's not make this appointment in the middle of the afternoon when the dentist may already be behind and has 20 patients in the waiting room. And, if you can do it like first thing in the morning, or way at the end of the day after things are quieted down, that's going to be more successful. I mentioned this before, speaking directly to the individual, allowing a little extra time, be realistic about what you can actually do in an appointment. Maybe you can encourage the dentist and their staff to figure out how they can actually pay attention to your needs and suggestions, both verbal and nonverbal, both ahead of time and at the time. So, and that might be just a matter of emphasizing the person's individual abilities, not their disabilities. For example, someone who's not particularly verbal, sometimes people think they don't understand things either. So you might be able to tell the dentist, well, he may not speak back to you, but he's totally understanding what you're saying. So please explain things to him. That kind of giving the dentist and their staff that information can be really helpful. Some other things that you can help them to think about how to plan a dental visit is give them some information on what's a typical day, what makes dental experiences go well, certain kinds of people being around, objects, how to approach the person, what kind of things historically have led to some problems, what kind of previous good or bad medical or dental experiences they've had, and just any suggestions or desires you have for the visit. So they all think about that ahead of time. Again, they're going to be appreciative of anything that can make the visit go better. And then additional information making sure they understand what the person's social skills are, their communication ability, both receptive and expressive, their sensory ability, if they're really sensitive to sights and sounds, it's really important for the office to know that. Frustration tolerance. If the person might be getting a little frustrated and that when they first start to get frustrated, you start to see this sort of twitching of their eyes. I'm just making that up, could be other things, but if you can tell the office that and they can watch for it, then that'd be a good time to take a break and stop. And so giving them any kinds of hints about how to detect when something's starting. You don't want to wait till there's a big explosion and everything's gone really badly. Start to detect some frustration really early. And then anything you can provide in terms of coping skills that have worked in other situations that the dentist might be able to use. Something else that you can do in sort of planning for a dental visit is to think about some familiarization visits. So if you're going to bring the person into the office, if they can have it be as routine as possible. So if they can set it up in the office that every time you come in, you're going to go into the same room and maybe the same dental assistant's going to greet them, and then change as few things as possible. So start with simple stuff and then gradually improve things over time. Try to establish some kind of routines in the office. So, maybe you can get the person to realize, okay, for the next, little bit of time, you're going to have your arms and legs quiet and we're going to count to 10. So for some people, it's actually critical they actually count to 10, that it makes it much more concrete. Okay, 1, 2, you're doing great. 3, we're working on your tooth. You'll feel a little vibration. 4, the actual counting helps some people realize, okay, this is not going to go on forever. I can hear the count going on. I know when I get to 10, I'm going to get a break. That's not necessarily what's going to work for everyone, but for some people, just helping the office figure out exactly what to do for that individual that's going to make it work better can be super helpful. And then sensory problems, as we mentioned earlier, there's some people that are very sensitive to sights and sounds and smells. And so, if the dentist can get the idea that if they can use the slower speed handpieces, which they can for some things, that's better. The high frequency noises really is, many people don't like to hear that high frequency dental drill sound, and if they can avoid that. And then for some people, actually using a lead apron over them just makes them feel more comfortable. May or may not, but if that's the case for the person you're working with, let the dentist know that. And then if they, if there's something going to vibrate a little bit, if the child can touch the vibration ahead of time so they can touch their fingers and know what that feels like. And then some kind of consistency, again, the same room every time they come in. And then finally, this idea of practicing either before or between visits. If you can help the person you're bringing to a dental office become more familiar with some of the things that are going on there before they get there, that is super helpful. It's so much easier if the person is already used to, for example, you can go to the drugstore, you can buy some gloves and a mask and sort of, play dentist, dress up like the dentist. You can buy these little disposable mirrors. You can look in the person's mouth using the mirrors. You can touch their teeth. So all that kind of stuff, sort of, use a light to shine in their mouth, all that kind of stuff. You can get them used to you doing that. Maybe you start to do that during your toothbrushing session. So they just get used to the gloves and the masks and the lights and that kind of stuff. And try to, go through the same routine as you think might work for the hygienist. So count to 10. If using an electric brush, if the dentist is going to have to do some drilling on the teeth, they'll feel some vibration. So an electric brush, they can kind of start to get used to gradually what the vibration feels like. So those are as much as you can practice ahead of time so that anything that happens in the office, the least number of new things to be introduced, the better it's going to go. And then finally, in this portion, I just want to bring in the idea of using social stories. Some of you may be familiar with social stories, but this is just an example of brushing my teeth. You can see that the language is very simple and straightforward. May not be applying to everyone, but for some people, reading a story, particularly for younger children. I know when my children were younger, they used to love to hear the same stories over and over again. So I can imagine maybe for some people you're working with, reading the story, at night I need to brush my teeth so they're clean. I put the toothbrush in my mouth. First I brush the back and the bottom. That's a brush the back and the top. I won't read through the whole thing, but you see it's very simple, very concrete language. And so that's something, if you can find these stories, they publish them. This is a book called Going to the Dentist. There are things online about social stories and videotapes. And even if you have a dentist who really wants to work with people with disabilities, but is afraid things won't go well, they can even when I lecture to dentists, I tell them, make your own book. You can do that so easily these days. You take photographs and you send it in and produces a hardcover book and have a picture of here's what the parking lot looks like. Here's what the office looks like. Here's what the receptionist looks like. Here's what the dental chair looks like. So that by the time the person comes into the office, they've seen all those pictures, they recognize it. It all seems somewhat familiar to them. Okay, so those are some tips about going to dental care. Again, if you have questions or thoughts about any of that. I see there's a question here about dental collapse in San Mateo sedation. How much is too much per year? I think the question's about how much sedation is too much per year. I'll tell you what, hold that question. So we're going to talk about sedation in a little bit. Sedation certainly has its place. None of those drugs are particularly good for you. Most of them are very safe that are used for sedation, but certainly if you can do without it or you can do with less of it, that's better. All right, so I'm going to move on now to talk about a different idea about dental visits. And this is something I've been working on for much of my career and more intently in the last couple of decades, about the idea of bringing care to where people are. We have this idea in our society that dental care happens inside dental offices, and it doesn't have to. There's a lot of things that can be done to keep people healthy outside of dental offices. So I have this diagram, which is looking at measurement and payment systems that are beginning to evolve to provide incentives for providers to keep people healthy as opposed to just doing procedures. I don't have time to talk about that today, but I do want to mention something about newer prevention and behavior science and then delivery systems. So we have all this new stuff, when I say new, 20 years old, we have all this new stuff in dentistry now, remineralizations and buffering agents and caries arresting medication and ways of sealing caries. And it's stuff that didn't really exist. It certainly didn't exist when I was in dental school, but that was a long time ago. I'm talking about things like fluoride varnish, which is this solution can be painted on the teeth a couple times a year. And it actually is really great at strengthening the enamel of the tooth so that decay doesn't begin. Even after decay is already there, this stuff called silver diamine fluoride, 1 drop of this can stop the progression of decay. So if you had a person, somebody who may not do very well with drilling on their tooth, a drop of that stuff can stop the progression of decay. It doesn't fill up the hole, so the hole's still there, may still get food. It has to be done periodically, but maybe the first thing you want to do is just stop the decay while you're there. So that's a new thing. We have dental sealants which have been around for a long time, but now we even know, even if you've got some decay on your tooth, a small bit, you can actually cover it up with a sealant and it doesn't progress. And then there's something in the last couple of years where dental hygienists can place things called interim therapeutic restorations, which they can, with no shots, no drilling, to sort of clean out the soft material in the tooth and place this filling, which can last for a very long time. So a lot of tools that can keep people healthy, and none of this stuff has to be done inside a dental office. It's all can be done, in a community center, in a residential facility, in a day program, various kinds of places where these things can be done. I have a question about, can 4 wisdom teeth be taken out at the same time for a 14-year-old child? Well, can it be? Sure, it can. There's no reason why it can't be done, but it depends on the child and lots of other indications. They may be swollen afterwards if you want to know, be swollen on one side so that they, swallowing difficulties. Those are all things that talk over with the dentist who's going to be doing it, but there's certainly no reason why it can't all be done at the same time. Okay, so now I want to just talk a little about various ways of bringing care to people. I start out with just some things about what's now called teledentistry. This is sort of the ability for people who are at a distance to communicate with each other, including dental providers. So, we saw a lot of this during the beginning of the pandemic, where providers were beginning to do what I call advice and referral, where, you chipped your tooth, you could take a picture of that tooth and send it to the dentist and they could give you some advice. Now there's these systems, the call center, where you can pay some money on a system and you can actually get some advice 24/7, either get some advice back on an analysis of some photographs you take of your tooth, or you can even talk to a dentist real time. Dentists are beginning to use these kind of portals to be able to have people sign up or give information pre and post visits. But I think the most exciting thing is when we're now beginning to see systems where dentists can actually connect their office to a community. Sometimes it's limited, where they may just be sending someone out to the community and collecting some records, but everyone's told to come into the office. But I think the most exciting thing is what I'm calling full service systems of care, where the idea is to get, not necessarily a dentist, it can be a dental hygienist or other member of their team, to actually be able to keep people healthy in the community and only use the dental office for more complicated disease that has to have all the techniques and materials that are available in the office. So we're starting to see lots more systems like this beginning to bubble up, even ways of connecting people together into these networks of dentists and providers. And so I'm calling all this stuff community engaged oral health systems. That's my word for a system where the main delivery area is the community. This is in residential facilities and day programs in community centers. And most people can be kept healthy there. And in the dental office, the dentist is involved, maybe reviewing records through the telehealth system, or maybe doing advanced procedures, but most people can actually be kept healthy outside of a dental office. And that's really a different way of looking at dental care than has been thought about for really a very long time. So I want to give you an example of one of these community engaged oral health systems. It's something we've been working on for a couple of decades now, called the virtual dental home. And in this system, I think if you were listening to maybe it was this morning where a former assembly member, Fraser, was talking about the dental hygienist and alternative practice. That's a special license in California for hygienists. So that's what this hygienist is. And they can go do a lot of things independently. So they're with her assistant, they have this portable equipment. They can go into one of those places I just mentioned, take x-rays, photographs, just collect a complete set of records, which can then be, once the records are collected, they go into this cloud-based system. The dentist can review the records and be able to decide what needs to be done. And then, sometimes the dentist will say, well, you should do whatever you can in the community, but they really need to come to my office. Or sometimes, no, I think everything that needs to be done can be done in the community. So there's a lot of things that can happen in a community site that like the silver diamine fluoride we talked about, like these interim therapeutic restorations. So instead of this child going from having a small hole to a bigger hole to a bigger hole to a toothache to not being able to concentrate to ending up in the emergency room in about 10, 15 minutes with no needles, no drilling, that could all be repaired, and that tooth could be in really great shape for many years. So we did a demonstration of this whole idea, community engaged systems. This was about more than a decade ago, 13 different communities, 50 sites across California. And we showed that you could actually have this whole idea we call telehealth connected teams work. You could have different people in different places. They could communicate together. And some of the results from that system were you could actually reach people who typically weren't getting dental care until they had advanced disease. You could emphasize prevention, get to them early in the disease process, lower costs. And then a lot of people can be kept healthy on site without going to a dental office. When we first did this, we saw 2/3 of children, but that was before we had the silver diamine fluoride. It's only been available in the United States for about 5 years. And now we're estimating 85% of children can be kept healthy at school. Think about that. Low-income children often have very great difficulty getting to dental offices, often don't get any care until they've got advanced disease. Keeping 85% of them healthy by early intervention at a school, what a difference. And it uses these techniques of continuous presence, having a hygienist there on a regular basis. It integrates in the community with the dental office, and the dentist is now involved. So they're not separate, dental office and community. It's all one community engaged system. And I want to show you, this is really one of my favorite pictures that I have, is this young man in his early 20s. He had all of his previous dental care done in the hospital under general anesthesia. That was just the way he did. That's the way how dental care worked for him. And we started this system. Now we have the hygienist. This is in his residential facility where he lives. He has the mask over his eyes because he didn't like the light, but he's totally fine. She's able to take x-rays. You see here, she's able to clean his teeth. She's able to do those small fillings. He may never have to go back to the hospital operating room again. And yet when he walked into a dental office, he was nervous, and the dentist looked at him and said, I can't work on this person. He needs general anesthesia. And so it's just an example of how adopting this community approach, getting to people in places where they're comfortable, can make such a big difference. Now, we're a long ways from actually having that available all around the state. There's lots of adoption challenges. I see there's one of the posting in the chat says, are there examples of California schools taking part in these community engaged? Yeah, there are actually. There's a big project been going on for 10 years in San Mateo County, and another one in near Stockton, and other places. So there are around the state, but not nearly as many as I think there will be eventually, as many as I would like to see. But some of the challenges are even just awareness, even for people getting the idea of, hey, this is a different way of doing things. That's still a challenge. Policy is still a challenge. There's still California is pretty good about that. We've been working for a long time, but still there's some things about what people are allowed to do, and some things that we'd like to be paid for still aren't paid for. And then even if everyone was aware and everyone knew exactly what to do, it's still not easy work for dentists. Typically aren't trained on how to do this. And so that's one of the things I do in my career now, is helping a lot of people to figure out how to do this approach. And we'll come back to that in a few minutes, talking about the next topic, which is this idea of shortening the line for sedation and general anesthesia. So a little bit of history about that. This is something that's not new. I was involved in this is a 2009 publication from a national organization called the Special Care Dentistry Association, with a consensus statement on sedation and anesthesia. And what it said, and this is getting to be a long time ago, what it said was, there's all these different ways of getting dental care to people. You can use general anesthesia in the hospital, or sedation, or just behavior support, or maybe physical support, or psychological or social prevention strategies. We tend to rely more heavily on the first two, sedation or anesthesia. And the reason that the other ones aren't used very much is they aren't paid for, people aren't trained, they aren't aware of it. There's various kinds of policy barriers. So I believe, and other people believe, that we still lean way too heavily on general anesthesia and sedation. Not that there aren't some people who absolutely need that kind of care. There certainly are. But there's many people who are getting care that way that could not need that kind of care if these other things were in place. So that was part of my answer when someone asked about sedation and anesthesia, how often you should have it. I say least frequently as possible, and preferably never. Or if you had it once, never again. So in a couple years ago in Sacramento, there was this big report produced about the problems with sedation and anesthesia in the Sacramento Dental Care program, and they listed several factors. Why were so many people waiting for a year or 2 years, or sometimes even 3 or 4 years? Why were these long waiting times there? Well, there was problems with reimbursement, with getting anesthesiologists to be able to accept Medi-Cal, with hospitals giving dentists enough operating room time, paperwork, dentists feeling that they had uncompensated time they had to spend and weren't getting paid for it, lack of training. And this is not new to California. This is really all over the country. And so the main recommendations, there was a bunch of recommendations. The main recommendations of those report were these two, which is expand operating room capacity for dental cases. And I don't fault that as a recommendation, but it's very expensive to do. And we're never going to solve this problem by just building more and more places where people can get sedation and anesthesia. In fact, the California Dental Association introduced a bill for providing $50 million in funding for people to build new surgical facilities around the state. It's not so clear what's going to happen with this year's budget, whether that money is actually going to be available. But even if it was, it would still be a drop in the bucket. We can't solve the problem that way. And so what I want to focus on is the second recommendation, which is support and raise awareness for alternatives to anesthesia. So if you picture this line, this is why I call it shortening the life. Picture this line of all these people that are waiting for their turn to get sedation and anesthesia, and the line is a year long, 2 years long. If you could take those people who actually could get their dental health improved or taken care of without needing sedation and anesthesia, and you could take them out of the line, then the line becomes much shorter, and then people who actually need that level of services could actually have it done in a more timely manner. So we came up with an idea about how to do that. Proposed strategies, behavior support and physical support and medical management using some of those new tools I talked about earlier, and then being able to bring care into the community and linking those community sites with dental practices. So in order to decide, is this really a viable thing? We had many, many meetings over the last couple of years with people from the California Regional Center systems, with behavior support specialists. So we had all these focus groups, and we asked them about what are the problems, what could make a difference. We talked to the behavior support professionals, asked them if you were seeing people that you're already seeing for various kinds of behavior support interventions, but you're not actually working with dental care. If you could actually work with dental care, how many people do you think you could keep out of the hospital operating room? They said 80%. I was sort of blown away by that. I think it's a little too high. I'm not sure they could be quite that successful, but I'm predicting 50 or 60%. So the fact that they said 80 made me feel better about my prediction of 50%. We asked the dentists, what are their barriers? And again, it's the same list of barriers. I won't go over it. And then we began to ask the dentists, well, what can make a difference for you? What would make you want to get involved with this kind of thing? So we said, what if we just did training about various disabilities? And they said, well, that would be somewhat helpful, but it wouldn't address the fees and the time and all these other challenges. Okay, so what if in addition to the training, what if we did training about both dental care and behavior support strategies? Again, somewhat helpful, doesn't address everything. What if we were to give you information, not only those things, but make sure that when a person shows up at your office, you have all the health history information, it's really clear to you how to get consent, how to get support in getting appointments? Well, that would be a little bit better, but still, there's other things that are not addressed. Well, what if every time a patient was sent to you, they were someone who was pre-screened, that the hygienist had already been working with them at a community site, and the hygienist really knew that they were ready for a dental visit, so that the chances of it being successful would be much better. And then when the person is referred to you, there could be a warm handoff. In other words, the hygienist could say, hey, here's what we've been doing in the person's residential facility. We've been doing this, this, and this. And so if you try that, these are the things that might make the visit go more smoothly. What if we call that a warm handoff it's not just a referral, here's a number of a dentist, go make an appointment, actually communicating with the dentist, coaching the dentist about what would work for that individual. They liked that, although it didn't solve all the problems. And so finally we said, what if we did all the above? We gave you additional training. We made sure that you got all the information you needed. We had linkages to the community where people are already getting care from the hygienist, and all the more simple things are already taken care of. You got training and support for using all these new modern tools. When you got a referral, it was really a very targeted referral, someone who knows you and knows the person, very predictable, it's going to work. And you also got some payment for some extra time if you had to do what people call a get to know you visit first. That's when dentist said, okay, I got it, sign me up, I'll do that. So it's not that there aren't dentists who are willing to participate, but what I've learned is we really have to think differently about how we engage dental offices, and we have to make it work for them, really. And this is a system that can make it work for them. So out of all that, we come up with a series of proposed strategies, which are really bringing care where people are in familiar locations, using all those behavioral supports to gradually introduce people to care, using all those minimally invasive prevention, early intervention things that we talked about, having a targeted referral to dentists, and then payment for non-covered services like desensitization and care management education. So we're really convinced now, we're already working with a couple regional centers launching these programs, that we're going to significantly lower these lines. And we hope in doing that, we would be able to build awareness, address the policy barriers that are involved in all this, and then lower all the costs of both the care and the costs of neglect. And then hopefully we'd be able to have some way to provide training for people around the state to be able to do this. So that's kind of where we were up until a couple months ago. And then a couple of months ago, I got contacted by former Assembly member Jim Frazier, who if you were on the keynote this morning, you heard him talk. And he works for the ARC of California. And he told me he had heard about the work we were doing. I explained it to him, and he said, that is fabulous. We got to do this. We got to do it across the state. So he was actually instrumental in introducing this bill that both he talked about and Assemblymember Rambula talked about. So the bill is AB 2510. And the language in the bill is that it requires the Department of Developmental Services to contract with the California, what says North State University, I think right now it says dental school, to establish a statewide program. And then the program would improve the provision of care for services to people with disabilities and prevent or reduce the need for receive dental care using sedation or anesthesia. Yeah, that's the bill text. So that bill is actually moving to the legislature right now. This was a hearing. Somebody in my office took a screenshot of it it was 2 days ago. It was on Tuesday this week. And there is a Assembly member Rambula in the middle, and former Assembly member Frazier. And this is me giving my testimony here. And what I thought I would just do, just to give you a sense of the bill and the kind of language we're using with the legislature about how to support this, but I thought I would just read you. It's only 2 minutes, because that's all you're allowed. When you do this, you're only allowed 2 minutes to talk. I'm just going to read you my testimony, what I said to the committee, and give you a sense of the kind of case we're making for why this bill is important and why it should be enacted. So bear with me. I'm just going to run through my testimony as if I was sitting in, you're all the legislative committee. So I said, Chairman Fong, committee members, I want to thank you and the bill authors, Assembly members Rambula and Dr. Wood, for this opportunity. I'm Paul Glassman. I introduced myself. I'll skip that for now. I've been working with California Regional Center System and providing dental care for people with developmental disabilities for close to 5 decades, a long time ago. I started my career providing dental care using sedation and general anesthesia. I actually taught hospital dentistry to residents and dentists. And I even wrote a book about hospital dentistry. Looking back, I think maybe I was kind of a slow learner, but it took me a long time to realize that as beneficial as these services were to some people with developmental disabilities, there were many people that didn't actually need that level of care that I was providing, but were having it anyway because they didn't have any other alternatives. And so I came to realize that it was really critical to do something about this, what I consider horrible and inhumane situation where many people with developmental disabilities were being told they needed dental care under sedation or anesthesia. And then they wait for 1 year, 2 years, 3 years, and in some cases, even 4 years to get these services. Actually, the president of the ARC of California, her son waited for 4 years to get dental care under anesthesia. He had a bunch of teeth extracted that she feels, and I'm sure she's right, that would not have been extracted if he had the care in a more timely manner. So this is really a terrible system. And so it's a terrible mismatch between the number of people who are referred for dental care using sedation or anesthesia and the availability of those resources. This has been documented for a long time. The Little Hoover Commission, the California Legislative Analyst's Office, other organizations have recognized this. And so I began to realize I was actually contributing to the situation by providing sedation and anesthesia for a lot of people who really didn't need it. And I began to change the direction of my career to try to figure out how do we keep people from needing this expensive and sometimes dangerous level of intervention. And so for the last several decades, I've been working with several regional centers to develop alternatives, and have led an extensive design project, which is what you just heard about a few minutes ago, including focus groups with regional center staff, behavior support specialists, and dental providers. And we've developed, and this bill will provide technical assistance and resources to spread this comprehensive and effective system that we now believe can keep 50 or 60% of people who are now in these horrible and inhumane waiting lines healthy, with less complex and less extensive interventions, and allow those people who really need that kind of service to have it more quickly. This whole thing would save tremendous amounts of money, improve the oral health of people with developmental disabilities, and reduce the suffering caused by the current situation. So I asked the committee to vote for the legislation. So that was my testimony to the legislature yesterday. And hopefully, if you are in support of this idea, you can go onto the website. You can contact Dr. Assemblymember Dr. Rambula's office, and they will certainly tell you when there's opportunities to be able to support either by letters or even showing up at a hearing. But to me, it represents a huge opportunity if this were to go forward. So we're so thankful for ARC and former Assemblymember Frazier for recognizing this opportunity and starting to lead the legislative activities that will hopefully, if it passes, you're never sure, but if it passes, lead through maybe a pretty significant change in the way that we use these complex and expensive resources, sedation, anesthesia, that maybe don't have to be used for everybody. So I told you I was going to allow time at the end, which is now. We got about 15 minutes left. So I am happy to spend the rest of the time talking about whatever you want to talk about. So anything that I've covered, I'm going to kind of look back at the chat here and see if I've missed any questions. I don't see any. So if I've missed some questions, maybe you can repost them. There's a question about, are there examples of schools that are taking part in the community engagement? When I was a kid many months ago, moons ago, right, me too. We used to do fluoride mouthwash as a class. Yeah, actually, fluoride mouthwash has been a little bit now replaced by the fluoride varnish. Fluoride varnish is actually much more effective. It's really easy to put on. I don't know, and I would love it if that was done on a regular basis in schools. It can be. It doesn't take a dentist to do it. It has to be done if you're doing it in a school where you have a non-dental person doing it. They have to do it under a program that's been designed by a dentist. So dentist has to figure out the steps and, train people how to do it, but the dentist doesn't have to do it. So it's something I think would be relatively easy to do, would be hugely effective, and I'd like to see it happen in schools across the state. But that's something that will require additional policy, additional awareness raising, additional maybe even talking to people at the schools that you were all involved with and saying, hey, there's a very effective things that you could easily do. Many schools feel like they're already so burdened with so many things they have to do that they don't really, even though they might recognize it's important, they don't want to take on one more thing, but you might be able to encourage them to think this is a really important thing. So encourage them to be able to add that to the list of things that they're already doing. Other questions? I'm not seeing any other questions in the chat. Oh, here we go. A couple more. Questions from my child is severely disabled with CP, has 13 years old, has never been able to do x-rays, so have to do his cleanings. And a dentist, how do we care for cavities or dental care? What about her teeth that grind down in the back? Is there x-rays important to her situation? Okay, so a bunch of questions there. Well, certainly for CP, it makes x-rays difficult. You have to hold still. You have to be able to tolerate the thing in your mouth, or you have to be able to sit still enough. There are some dentists who have a machine where the film doesn't actually go in the mouth, and The older versions of those things, the thing had to turn around your head and you had to sit still for 20 seconds to be able in order to get x-rays. The newer versions, which many dentists don't have, but some of the more modern dentists or bigger clinics might have, it's actually very quick. They can take a quick x-ray and it shows the whole mouth in one film. So that's an option. It might still be possible to get some x-rays done. X-rays are useful because it's hard to see between the teeth, just looking in someone's mouth to know if there's something going on there, or if there is a cavity, how deep it is. X-rays are useful, but they're not absolutely essential. So let's see, a couple of questions. Well, what about grinding their teeth? Yeah, so that's a common thing. People with CP, although other people do it as well, grind their teeth, and some kinds can grind them down pretty severely. There are some maybe things to do about that. There are some plastic mouth guards that can go over the teeth. And then when you're grinding, you're actually grinding down the plastic instead of grinding down your teeth. Not everybody can tolerate one of those in their mouth. Even making it requires some things in the mouth to take impressions. But that's an option. So you might want to talk to, if you have a dentist, to talk to them about whether some kind of mouth guard will keep them from grinding your child's teeth even further. And then if they do have cavities or dental care, well, again, there's multiple ways to do it. So before I thought about, was my child, before I thought about going to the hospital operating room, you know, you certainly could do all that with x-rays and complete dental care in an operating room under general anesthesia. But certainly before I did that for my child, I'd want to make sure we tried everything else first. And so depending on the cavities and which part of the tooth they're on, maybe just a drop of this silver diamine fluoride can actually stop the progression of that decay, put it into a holding pattern for a long time. Maybe there's a hygienist nearby who can place one of these, it's called interim therapeutic restorations, which is no shots, no drilling, just a very quick sort of scooping out the soft material in the hole in the tooth and bonding some tooth colored filling material in the tooth. So there's a number of things that can be done short of the general anesthesia. And then of course, the stuff I talked about in the first part of this presentation, anything you can do to make sure that when you have a child where the dental care is so difficult, anything you can possibly do to establish what I would say meticulous daily mouth care, you know, don't have any sugar between meals, making sure they're brushing and flossing to the extent that you can get them to do that. You know, if they do have some sugar, brush and floss if you can afterwards, all those things that you can do to try and keep them from getting dental disease. Now, if they've already got some cavities, obviously those need treatment. So I would try first with the silver diamine fluoride, the interim therapeutic restorations. There are dental hygienists with the RDHAP license that will come out to, some of them will even come to your home. Now, typically, most of them don't do that on Medi-Cal because they don't get paid enough to do it. But if you have the ability to pay them to do that, there's hygienists who do that. You can look at the California Dental Hygiene Association website and look for a list of RDHAPs, and some of them are actually on there advertised, and you can contact one of them. They have the ability to go to a school, a residential facility, any kind of institutional setting and do these things. So that would be a great way to start with dental care. And then I'd say the last resort would be if someone determines, yeah, there's some significant disease going on here, then they might have to be scheduled for sedation or anesthesia. As I said, there's long waiting lists. It's not a really great answer for many reasons, including you can't get it done quickly because of these waiting times, depending on which part of the state they're in and what kind of insurance you have and a lot of other variables. But I would try everything. If it was me, I would try everything else first before doing that. Okay, we have time for a few more questions. I'm not seeing any others in the chat, unless Mariah, you are seeing anything else from the Q&A, because I'm just looking at the chat. I'm not looking at the Q&A. So if you can, don't see any other open questions. Well, I just finish up with a couple of thoughts, you know, still, if you time for you to put in a few more questions, if you come up with them. I see nothing else in the Q&A. Thank you. Yeah, so we got a few minutes left, but if we end early, no one's going to complain. So this has hopefully been helpful. You know, I've tried to sort of go across the spectrum from just things you can do at home with your own child or someone you're caring for, to, you know, working with dentists and practices in a dental office to make those go better. And then lastly, about this idea of just changing policy and changing our approach to sedation and anesthesia, which is the most costly and complicated and, to me, the least effective way of having someone have a lifetime of dental health. Because just because you had someone have their teeth fixed under anesthesia doesn't stop the progression of new decay. And if you don't do something to stop that or be able to treat small things when they're still small, it's just a bad way to certainly on a habitual basis to do it year after year. It's a bad way to do it. And so anything we can do to try and keep people healthy without that, I think we're all better off. A question about silver diamine fluoride. Is there a small cavity suspected? It can be used actually if there is a little hole in the tooth, small to medium size hole. It can actually be used if even if there's like a dark groove and you're not even sure there's a cavity, you can actually put it on that as well. You can also put dental sealants on the small grooves as well. So either one of those, and if you're working with a dental hygienist, they could certainly be able to advise you about which one of those things to use, but they're both effective when you have small beginning cavities, or even if you suspect that there's a cavity, either a sealant or silver diamine fluoride. Both of those things work and actually can stop the progression of the decay. Is there a registry that list of dentists who specialize? Yeah, unfortunately, there is not. And many dentists don't want to have their name on any kind of registry because their experience is as soon as their name's there, they get flooded with people calling their office and they don't want to be flooded. So that's the challenge, which is why another reason why I've been pushing, we don't need a dentist to treat every dental problem. If we can get stuff done in the community, then and using hygienists, and there's a lot of hygienists who are beginning to get trained and learn how to do this kind of work, I think we're all better off. Opportunity interprofessional collaboration. Don't have enough hygienists, don't have enough dentists, can nurse practitioners or physician assistants. Absolutely. So thank you for that, putting that in there. So in California, both the physicians and nurses are allowed to place silver diamine fluoride. They're allowed to place fluoride varnish. And so that's something that can be, and they can get paid for it actually in the Medi-Cal system. There's been a lot of work to try to train and raise awareness among the physician community about the fact that they can do these things in their office. Sometimes you get some pushback because, again, it's the same thing as talking to a school. Sometimes people say, boy, we have so many things that we have to do on a well child visit, for example. We don't want to add, we already got 46 things. You want me to add number 47? So it takes some education and some encouragement to get them to do it, but they're certainly legally allowed to do it. And many physicians and nurses are beginning to do that. So it's a great example of interprofessional collaboration. Some other examples are there's some places now where, particularly in some health centers where they have an integrated medical and dental system, where someone goes in for a pediatrician visit or an OB visit, and the same visit while they're there, the dental hygienist from the dental clinic comes over and actually does a screening exam and can do some of these things that we've been talking about. So more and more work, and it's a great thing. Thank you for raising it about the idea of making this not just a thing that dental professionals do, but other people can get involved in. Is there a work group for us parents to join and support the dental community? That's a great idea. I'm not aware of one, and maybe we can even do some work with Family Voices, because maybe that would be an opportunity to raise some kind of a. And there are a couple other things, but we can actually talk back with the conference organizers and see if we want to provide some information to those that attended the conference and see about organizing something like that. I'd certainly be willing to help out with that. Try to make notes. What was the second item you used for small holes or cavities? So silver diamine, it's DIAMINE. And again, you'll get access to these slides, I think. So that's a drop of the stuff. It turns the tooth black, but actually it's better to have the tooth black and have the cavity stop, most people think. And then the other one is called fluoride varnish. And fluoride varnish you can use when the tooth is first beginning to dissolve, before there's a hole in the tooth, and the silver diamine is after there's a hole in the tooth. Opportunities for nurse practitioners to attend dental school for the interprofessional education. Need to know what we can do. Yeah, there's a lot of webinars that have been done for professionals, and I don't have a list of them off the top of my head, but I bet if we did a search for, say, Google search for dental care for nurses, there would be downloadable, sort of on-demand education. In terms of actual education experiences in dental schools themselves, there are some schools that are doing that. I know UCLA, their dental school has a collaboration with a nursing school, which is right next door. At California North State University, where I am in Elk Grove, and soon in Sacramento, there's a nursing school that's starting up. So as soon as we have a nursing school starting up, we're going to start to offer more interprofessional things like that. I don't think there's a lot of that out there, though. So again, it's something that we could pursue. And if there's enough demand for it, I'm sure we could find someone interested in doing something like that. So it's a great suggestion. I appreciate that. Okay, so don't see any other. I'll just maybe finish up by saying, first of all, thank you for being here and for attending this session. I hope it was helpful to you. And then particularly if you're interested in the work about the new system, potentially an AB 2510 that could help to spread across the state the methodologies for keeping some people from needing sedation anesthesia, I really strongly suggest that you contact assembly member Arambula's office and get on their list, and they would tell you when there's opportunities to write letters or new hearings that are coming up. I think that's going to be super useful if that bill passes, and we'll be able to have the support to be able to spread this kind of idea across the state and do both training and support for a lot of different people to try and end this terrible, inhumane, years-long waiting list for that kind of care and have people have care more effectively and with less complicated interventions. So again, thank you for your attention. Appreciate the opportunity to talk to you. And let's see, I think I need to just show the last slide here to close this so we can have our interpreter. And if you just would maybe translate that last slide for folks, and which you're probably already doing in the interpretation. And then, yeah, we'll see you back in the main room for the rest of the conference. Thank you, everybody.